So, dear friends, we all in this room, we work or medical or paramedical in sports. Whenever there's a problem, the only real question that we get at the spot is not, will I be able to play in 5 years? Will I have detrimental causes when I'm later at the end of my career? It's when can I play again, from the coach, the club, and from everybody around. Return to play, that's the point. Now, if we consider ankle pathology, let's have a look. There we go again. Okay, so a quick video just to explain you that when we talk about an ankle injury, most of the time people say, I twisted my ankle, I got a kick, and we all call it an ankle injury. But look at these images. It's always something different. It's from the back, it's from the side, it's due to a kick, it's because of a pivot, it's stuck, it's due to a contact, it's always different. So don't call an ankle injury an ankle injury. We try to make a comprehensive meeting on ankles to discuss cartilage, impingement, ligament, fracture, and all the other kinds of instability that go around in that pathology. So just in summary, there is no such thing as a simple ankle sprain. There's a wide range of possibilities, pathologies, but also of opportunities. And that's the point. Now, if we talk about stress fractures, because you've just seen a contact problem, but if you have overload, you talk about stress fractures. How do we call that? Nomenclature is very important. It's a microfracture in bone that results from repetitive physical loading below the single cycle failure threshold. That's how we call a stress fracture. And if you look at data from our friends, for example, Jan Ekstrand, you see that every 25 players can have every third season one stress fracture, a group of 25 players. It's always in the lower extremities. It can cause absences up to 5 months, and you have very frequent, up to 30% re-injuries, of which the risk factors are mainly young age and intensive pre-season training. Good to know if we talk about it. But the question is, at what stage does the player present to us? Is it at the silent stress reaction phase where the pain is still low? Is it developing, or is it already at the threshold where you can see it on imaging? Of course, the diagnosis can be through X-ray. We used to use the bone scan with CT scan, very helpful, by the way, but nowadays the MRI is really our guiding light in treating and acknowledging these pathologies. The real question, as I stated, is when do we call the player ready for return to play? What is the moment that we say it's normal again? Because if you look at it clinically, the pain resolves after a few weeks. If you look at it on MRI, it's a few months. If you do a bone scan, it can give that take-up up to 2 years. And if you do CT scan, you see the stress fracture up to 6 years. When are we ready? When is he able to play again? What's the moment of return to play? So can we predict the severity from imaging? We've had wonderful literature already, also from our center, on how MRI cannot identify the return to play for hamstring injuries, the most common football injury, of which tomorrow's session will be very highlighting that. Can we use it in our ankle pathology? In tibial stress injury, it's even negatively related with clinics, the MRI. X-ray, bone scan, and CT severity are not related in time to healing, but we see a positive trend with MRI, so maybe we can in the future. Of course, the majority of stress fractures, they are easy to manage. We avoid the aggravating activity, maintain the fitness, identify the risk factors, and gradually do progressive load management. And that's a nice algorithm that I like. The high-risk fractures, like the navicular, the 5th metatarsal, if it is a fracture on the tension side, you do surgery. On the compression side, you go for non-weight-bearing immobilization, and also no cortical disruption on imaging, you go for fracture immobilization. If it's a low risk, you do more load management and progressive activity loading. But unfortunately, there are these difficult stress fractures, as we call it, and I'll run over a few with you. I already showed you the talar stress fracture that we approach through a posterior side, and that shows good results with surgery. But on the opposite, For example, when you have a navicular fracture, the literature tells us that you should not operate. Why? Because if you put these players in a non-weight-bearing cast, your return to sport is quicker. If you put them on a non-weight-bearing cast, less than 6 weeks, you get them quicker back to return to play, and you can compare surgery also. A retrospective analysis showed no difference in the management between surgery and conservative in return to play after 2 years for navicular fractures. So the type of fracture is really prone to the type of treatment, whether you consider surgery or not. Now, a nice meta-analysis showed that 96% of the navicular stress fractures treated with 5 weeks non-weight bearing went on to successful outcome and return to play. Surgery 82, but if you give it a weight-bearing cast, it's only 44%. So consider the non-weight bearing, stress the compliance of that to your athletes. Of course, we have some surgical opposing views showing that normally the conservative strategy is considered by the athlete as frustrating and prolonged, and there are individual cases for surgery. But in general, you can compare surgery and non-weight bearing cast with good results. Why do I put this slide? Because a stress fracture can be terrible. If you look at the American newspapers online, you see that many of the NBA players, we have one coming in next week, by the way, with a navicular stress fracture. They are out for many months. Why is that? Because it's difficult to treat. So we have to find out how to deal with that. The right side, you see the three brothers Borlée, which are our Belgian pride, the golden medalist champions indoor in estafette, of which Jonathan was out for 8 months with a navicular stress fracture. It's not a little thing. It creates, for a team, for a player, a big challenge. Now, of course, we have that fifth metatarsal stress fracture, but don't always call it a stress fracture. You can have avulsions. You can have the Jones fracture, as we call it, that involves the intermetatarsal joint. And of course, you have the stress fractures more to the proximal side. So nomenclature is very important here. We have a very nice article from our friends again, showing that in more than 7,000 athletes, you can expect a fracture every 5th season, which is not so bad. But the mean age is young, and the surgery treatment has shown very, very accommodating to treat that injury compared to non-surgery. So for navicular, it's more non-weight bearing, conservative. For metatarsal 5, it's more surgical. As we said already, a la carte treatment during the whole conference in our elite athletes. The worst or the most interesting finding in that study for me was that there were up to 45% prodromal signs. So if you're a person interested in prevention, if you're a researcher, you want to know why. 45% of these players could have been detected before they made the fracture. Isn't that interesting? Now, of course, the surgery is minimal invasive, percutaneous, gives good results, and the players are happy. But you have to know that if you have a Jones fracture or a stress fracture in your athlete, preferably surgery is taken into account for getting a quicker return to play. And if you have a non-union or a stress fracture, you preferably consider a bone graft as additive treatment to that strategy. Wonderful work that is still in development by our amazing colleagues from podiatry and Aspetar. Just to give you an idea, an athlete operated for a metatarsal 5 stress fracture that led to healing after 2 months on X-ray shows this slide on the plantar plate testing. We acknowledge the work of Craig, Athel, and Ken here in the room. So look with me on the left side. So again, I didn't explain you, but this is from the screening. So before the surgery, we have all the screening of our athletes. But look, after 2 months, when we considered the fracture on X-ray healed, the athlete is not loading on the healed fracture after 2 months. After 3 months, he's not loading on his healed fracture. What do we consider return to play? Put that in your back head. Look at 1 year. The athlete is not loading that area. Look at 2 years. And we can go on. But this is at 3 years, no loading compared to a normal site after sustained the fracture. So 3 years after that fracture, he's playing, of course, after 2-3 months already, and still he's changing. So are we really solving the problem when we adopt to changing loaded patterns, and if we overload other structures? Are we doing the right thing? So that's the point. Can we then, if we discuss what we have to do, we know from literature, if we discuss we're still not there in getting our loading patterns correct, can we at least accelerate the loading through these things? A quick roundup. What about the brace? The brace says that the time to resume activity would be beneficial in accelerated healing. Is it true? Well, light activity 9 to 32 days and full activity 29 to 82 days. You can't make any strategy on that. That's too big interval to say it works. What about electrical stimulation? There is some evidence, but no effect in minor stress fractures and better compliance and weight-bearing reduction seen already, so you can't really say. A Cochrane review shows insufficient data to support that that works. Another, in animal and in vitro studies, we see some osteoinductive effects. But in human trials, it's controversial and it still needs to be shown because it works for delayed union, smokers and diabetics, but that's not our population in our sports athlete. Now, luckily, in the newspaper, for example, 2011, we see shockwave. It's the new thing. A new non-invasive treatment using shockwaves is revolutionizing the way we heal our broken fractures. Interesting. Revolution. If we look at the data, it shows that shockwave shows 3 to 6 months return to play healing and 3 to 10 months. Is that so much better than our classic strategies? I guess not. What about anti-inflammatory drugs? There will be a nice talk on that tomorrow, especially in the overuse of it in the athletes. But if you have a fracture, it may even inhibit the healing compared to promoting the healing. And what about bisphosphonates? There's no help in prophylaxis, and we've seen by a study by Lars and his group that there's, at this stage, no conclusive evidence that bisphosphonates accelerate the healing in the stress fracture of our athletes. So what about the parathyroid hormone? Still to be shown, but too limited cases to really know. A last word on vitamin D, a big thing here in the region because there's a kind of problem with vitamin D into the level of the blood of our athletes. We see that inadequate sun exposure and poor dietary practices give vitamin D deficiency in our athletes. And we've seen that in wintertime, between August up till December, there are insufficient samples in 65% of our athletes. Is there a relationship? We know there is, and we recommend the high dose, the doses specifically tailored for our athletes. So the data is out there that at least vitamin D can be beneficial in accelerating the healing. We know that we have to get our players between 30 and 50 nanograms per milliliter, and that we can increase the athletic health performance if we put them up to 50 nanograms per milliliter, but higher there gives a plateau phase. So the recommended intake is there, and I just want to finalize by saying that the industry is pushing us to new limits. We always are used to use sport shoes where we do a hindfoot heel strike, but nowadays the barefoot heel strikes are into the fashion. But we do see increased bending moments onto the, for example, metatarsal 2 now. So we are seeing new pathology, new stress fractures due to the industry pushing new types of shoes with new strike patterns. And a study that was shown by me by our podiatrist. For example, you have the barefoot industry runners and the normal sport shoe runners. They put them on an MRI before running and 10 weeks after running. You see, in the barefoot runners, 10 to 19 runners had bony edema and 2 had a stress fracture already, compared to the control group with the normal sport shoes and the different strike pattern that only had some edema in 1 case. So are we not pushing the limits and even developing new problems? Of course, we have the amazing facility to check the strike patterns. And the last slide I want to share with you, and this is really work from our podiatrist. Let me take you just on a big slide that wants to share one information. If you have the body weight over here, so you can run at 100% or at 50% in the water or on the Alter G, and the speed here. When we talk about return to play on our athletes, if you put them on 8 kilometers per hour, that's walking for them. If you train them to return to play, you want them at their level of training. So can we do that? If you look at 8 kilometers per hour on 100% body weight, you see this figure. But if you extrapolate that to half of the body size with 16 kilometers per hour, which is the level they reach for getting back into a full training biotope, you see that we get about the same plantar force on our plates, meaning that we can use the Alter G and the water to already get them back much quicker on a more body type of position before the fracture heals already completely. So the idea is, can we return to play quicker? Probably not with all our tools we have surgically or biologically or through tools that are technology, but we might facilitate that strategy with physiotherapy by reducing the body weight training, by getting them back quicker in their environment of training, and hopefully that will result in a quicker return to play. And I want to acknowledge our amazing podiatry group, and I thank you very much.